Good afternoon, everyone. Thanks for joining us. We're going to give it about a minute, minute and a half here to fill the room up. Good afternoon again, everyone. We'll give it about another minute to fill the room here. And we'll give it about 30 more seconds to fill the room. All right, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on artificial intelligence and machine learning research in hemophilia. My name is Brett Spitali. I'm a Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, July 23rd. I'm joined today by Dr. Mike Recht, who's the Chief Science Officer at the American Thrombosis and Hemostasis Network, and Moses Miles, who is the Chief Operating Officer over at Athens. Thank you both for joining us today. We truly appreciate your time and expertise, and I'll turn it over to you to get us started.
Great. Thanks, Brett. As Brett said, my name is Moses Miles. I'm the Chief Operating Officer. So I've been with Athens for about 10 years or 11 years now, and really came about along the technology side and then sort of worked my way up to being the Chief Operating Officer. So today we're going to talk a little bit about, just to give a really quick overview of what Athens is, for those who may have some questions about that, talk a little bit about what artificial intelligence is and how that differs then from machine learning. And then we're going to talk a little bit about what we're actually doing with these techniques at Athens. And Mike's going to really drill down into a specific project where we're applying these techniques to the data that we've collected. So really quickly about Athens. So Athens is a nonprofit. We're focused on improving the lives of patients with bleeding and clotting disorders. Now, for those who don't know, Athens actually grew out of the Hemophilia Treatment Center community, wanting to create an organization that could actually host the data that was being collected in all these different treatment centers around patients, and to make that data available to support research and to improve clinical care techniques as well as future treatments. So Athens is that organization. To support that mission, we actually provide a significant amount of support to HTCs in the way of technical infrastructure for data collection analysis. We have a number of different tools or solutions for that. We have an electronic medical record system. We have a tool for managing research studies. We also have some patient-facing applications that we've built over the years. So, of course, many of you know about Athena Data Set, but we actually have a new app coming out soon here called Robust Health that we're going to be talking about at the NHF conference next month. So I really encourage you to come and listen to that talk as well. We also maintain the Athens Data Set, which I'll go into a little more detail in our next slide here. We also sponsor investigator-initiated research projects. And lastly, one of the big things that we do is that we actually perform the analysis on that data. So we're going to talk today about some of the techniques we use to do that analysis, and machine learning plays a big role in that. So really quickly about the Athens Data Set. So that's a de-identified data set. And what that means is that the data in the Athens Data Set cannot be linked back to a person. So we go through a lot of work to make that a reality. So we go through and we strip out all the health information of the public health information for people around, for any patients that's contributed their data. We also, go through this exercise where we bring in a third party who actually looks at the data set, compares it to other data sets to make sure that there's no way you couldn't mix and match data sets to try to identify the data that's collected. They perform a number of really advanced statistical techniques to do this. And this is all done in accordance with the guidelines from HHS and other federal organizations. So we're really confident that this is a truly de-identified data set. The data we have consists of it comes really from you all. You've chosen to contribute your data to the data set, We have more than 43,000 patients that have actually made that decision. And this is great because it provides this fertile ground for researchers to explore. And so that has worked out in a couple of different ways. So we have more than 50 projects that have actually had some type of publication from that were Athens Data Set projects where the data was used directly. And then there have been times when we have, researchers who have a specific interest. They'll go look into the Athens Data Set, try to answer their questions. Maybe not all the data is there, and then that will end up, creating a new research study that then will work with them and funders and others to actually put together the project, get the project kicked off, and then provide the ongoing support for it. We've had a tremendous amount of success in sort of going down both those paths, and really all of that is really due to you. So I just want to, from everyone at Athens, just to say thank you for all of your willingness to contribute data and participate in those projects. So let's talk about artificial intelligence. So Hollywood has really done a number on artificial intelligence. It has really been confused with basically robots trying to kill everyone or wipe out the human race. So it's not that. So we could just level set there. Really what it came about was the idea of, you can think of sort of the father of computer science. That's Dr. Alan Turing. He and then others who followed him, like John McCarthy, really were thinking about artificial intelligence as machines that could think autonomously. So you can see here with John McCarthy's definition, it's about really getting a computer to do things which, when done by people, is said to involve intelligence. That definition has been refined over the years. So you can think of AI today more along the lines of machines responding to stimulation that is consistent with traditional responses from a human. So if I were to scare you, that the machine would actually respond in the same way that we would expect, right? Because it would know that's the natural reaction. So this is sort of the way we're thinking of it. Usually it involves things like contemplation, judgment, and intuition. So we're going to talk a little bit about what that means going forward here. So in terms of intentionality, this is about really making decisions. And so a good example about this is when you have like a self-driving car, and it is able to use all the sensors that it's had, this LiDAR, its camera, and others, to say, you know what, there's an obstacle and I need to address it. I need to make a decision. And then, so that's the idea of this concept of intentionality. When we think about intelligence, we're really thinking about about being able to make predictions. So, if I take all this data in, if using the self-driving car example, I can see that there are options, right? So I can see, I can predict that if there's a pothole and a puddle, and then there are pedestrians who might get splashed by the puddle, I can predict what's going to happen. So if I hit the pothole at the speed that I'm at, I might damage the car. So that's what the algorithm is thinking about. Then if I see on the other side, if I hit the puddle, the only thing that could happen is potentially people might get wet, right? So it might choose to go through the puddle, knowing that the alternative choice is it's damage to the car, right? So being able to understand and balance those priorities, sometimes those priorities can be conflicting because they may have a directive, not to harm a human or endanger a human in some way. Those things are all things that it has to balance out, right? So that's when we think about intelligence and that decision making. A lot of times that uses machine learning to create those predictions, right? It knows from experience that, if you hit a puddle, that it will splash, and then the consequence of that is people might get wet. So when we think about adaptability, it's about changing the intentions based on the new conditions, right? So when we think about this, using our driving car example, it's like, being able to adapt to new conditions. So it might be going along and everything's fine and it's working, there's no issue with the road, and all of a sudden it comes up to the pothole decision, right? Being able to adapt to that, to make a change and not rely on predetermined responses. So, when you think about these three together, they all sort of work together. It's hard to say that each of these are completely separate. They sort of overlap. And even when we talk about machine learning being a part of even some of how that decision making is being made. Which leads me really to machine learning and what that actually is. So if you think about this triangle as being artificial intelligence, machine learning is a branch of artificial intelligence. And then, what it does is it takes a look at all the data that it has and then is able to predict trends, right? So typically you hear people making statements like, we train the model to do something, right? So we expose the model over and over to similar sets of conditions so that it is able to pick out, say, when I can pick out a dog from a picture, right? Because it's seen enough pictures of a dog to know roughly what a dog will look like and is able to identify that. But it does that because it has this huge database of pictures of dogs and is able to find that similarity. So that's the idea around machine learning. A lot of times it's used interchangeably with ideas like deep learning and neural networks. Those are really specialties of machine learning. So if you start with artificial intelligence as the most general concept, then more specifically, there's a branch for machine learning. And then from there, there's deep learning. And then from there, there's neural networks. So when you think about machine learning and identifying these trends and training it, that training the model or the algorithm or program, you can sort of use those words interchangeably for the purposes of our discussion. That it really is where there's a human and the program, and the human's feeding information in. So maybe pictures of all those dogs that I mentioned previously, and then as it gets responses, the human is tweaking the model over time, right? So we might change the data we're putting in, we might be tweaking the model so we know to get the response, so that when we then take the model and give it a data set it's never seen before, we can predict how it's going to respond to that data set. So that's what machine learning is, and that human component is a big part of it, right? The big part of the training. Deep learning is the same thing, but we pull the human out, right? So the machine is able to do the tweaking and learning on its own without the machine being so involved. Neural networks is effectively the same thing, except in the deep learning that's occurring in individual nodes. So those nodes you can think of as neurons in the human brain. So we organize multiple algorithms or multiple models on the same model as the way that the human nervous system works. And then when we have those different neurons sort of working together to solve problems and address issues, right? So that's the sort of level of specialty in terms of how sort of machine learning and artificial intelligence are related to each other. So what we're doing at Athens, we're really going to be focused more on traditional machine learning, where we have the human and the model working together as we're analyzing data and then creating the model. We are not really applying deep learning and neural networks. It's not that we're not open to it. We just haven't found the right question that really requires those level of techniques yet. That being said, even with just using traditional machine learning techniques, that represents a significant advance from the current way we've been analyzing data. And it's going to open up all sorts of new possibilities for us to be able to think about, new solutions or new treatments or identifying trends, things that might actually be impossible using more traditional analysis techniques. So then I'm going to turn it over to Dr. Recht, who's going to talk really about what we're actually doing with one of our specific projects. Mike?
Thanks, Moses. I appreciate it. And thanks to the NHF for giving us this opportunity to talk about this issue in general and then about this specific project. So when I came over to Athens about 1.5 years ago as the Chief Science Officer, my charge from Moses as our Chief Operating Officer and Crystal Watson as our CEO was to organize and align all the research and registry projects that we were doing at Athens, as well as seeking other opportunities for research and program development. So about 1 year ago, probably, Pfizer Medical Grants Program put out a request for proposals for projects looking at the use of artificial intelligence and machine learning in hemophilia. And just to give you a little background why this is even important in our field, people on this call know that over the past 10 years, there have been tremendous advances in how people with hemophilia and bleeding disorders in general receive therapy. And there are new therapies, whether it is the bioengineered molecules that make factor last longer, whether it is using different sorts of systems to produce factor that is more human-like, so with the potential of having less inhibitor as a result. Emicizumab certainly has completely changed the way we prevent bleeding in the hemophilia population in those people who have elected to go onto that medicine. However, there are some barriers that potentially inhibit people deciding to move to some of these new treatments or some of these new technologies. And one of those barriers is really the difficulty that medical providers have with figuring out who with hemophilia is really at risk for having some sort of poor outcome. And that's what we at Athens wanted to help people figure out. How can we use the data that we collect through the various Athens systems to help providers and individuals affected by bleeding disorders understand if they are potentially at risk for having a poor outcome. Now, we can't do this all by ourselves. Although we are essentially a technology company collecting data for the various projects we do with the treatment center network, we don't have the expertise for this kind of project. So we reached out to our friends at the University of California in San Francisco, the Center for Digital Health Innovation. Now, the Center for Digital Health Innovation was founded about 10 years ago, and their mission is to create and accelerate development of digital technology that's necessary to transform the delivery of care, not just for people with bleeding disorders, but care in general. Their goal, I think I really like the way they state their goal. Their goal is to bring the right treatment to the right patient at the right time. And the people at the Center for Digital Health Innovation have been collaborating with scientific innovators to really help realize new solutions to improve the lives of patients. They bridge these emerging technologies in the healthcare systems to drive the innovation that brings these new ideas to life. They've been on the front line of artificial intelligence. The director formerly worked at Google, Moses, is that?
I think he's been at Google, Intel, and one other place.
Yeah, so this is a guy who's got a lot of experience in the corporate world with this. And then he came over to an academic setting to help researchers really take what he helped develop. So as an example, one of the projects that the Center for Digital Health Innovations have been involved with is working with radiologists to develop an FDA-approved device that actually reads chest X-rays. So instead of having to have each individual chest X-ray that is performed at a hospital or a health system looked at by a bunch of different radiologists, their system allows this machine to interpret the chest X-ray. There's always a check by a radiologist to make sure the reading's right, but it has really sped up the interpretation of chest X-rays. It has standardized the way chest X-rays are read. So this is one of the groups that we collaborating with. And then of course, we're collaborating very closely on this project with the National Hemophilia Foundation, particularly their Community Voices in Research app. And I'll tell you how we are collaborating with them. So there's a couple of objectives for this project. The first is to demonstrate the feasibility of using machine learning. So what Moses talked about with machine learning to predict people with hemophilia who would most benefit from a potential change of therapy, because from our machine learning, we would predict that they would have a poor outcome, and potentially even using this to say, yes, this person might benefit the most from a one-time treatment such as gene therapy. So before we can take that big step, one of the things we had to do was actually come up with a definition of poor outcome. And, as a clinician and as a clinical researcher, I have in my head what a poor outcome might be. But what we didn't know is, what do patients or patients' families or patient caregivers define as a poor outcome? And I'm going to talk about how we're going to come to this definition. Once we figure out this definition, and we're a long way down this road, we're going to use the data from our big natural history study. So Athens 7 is a study that is open at 26 different centers across the United States Hemophilia Treatment Center network, where we ask people with hemophilia whether they would be interested in enrolling. And then we collect a much deeper set of data and a much more reliable set of data, because we're asking specific questions. The data in Athens 7 differs from the data in the Athens Data Set, in that Athens 7 is an actual study. So there are specific questions being asked. The answers are being entered into Athens data systems the exact same way at every center across the country. So we can really, it's really the best level of data that we have through Athens. We're going to use that data to help the machines develop a protocol that will predict poor outcomes. And that poor outcome is going to be from the definition that we're working on right now. Once we use the Athens 7 data to help develop this protocol, we will then use that protocol and apply it to the Athens data set. So remember, Moses said there were 43,000 people in the Athens data set. About 9,000 of those people have hemophilia. We will take this protocol that we have developed using the research level data from Athens 7 and then apply it to the data that's in the Athens data set. The whole idea is to help us determine whether we can come up with a model that will predict poor outcome, whatever that definition is. So if we can move on to the next slide. So we're going to develop this model of poor outcome from two different perspectives, from the provider, medical provider perspective, and from the patient caregiver perspective. So let me talk to you about how we're working with the medical providers. So we generated a survey that we sent out to all Athens affiliated physicians and clinical researchers. After the survey was sent out, we sent out a reminder after 3 days, and then we closed it after 7 days. We didn't want it just lingering. What we asked them to do was rank a list of what had previously been in the literature identified as poor outcomes, and rank these on a scale of, I think we had 11 different choices. We asked people to say, which do you think is the highest ranking poor outcome and which is the least ranking poor outcome? And if you click again, you'll get a table of the outcomes that we asked. So if someone is dug deep into the hemophilia literature, these are the kind of things that you hear about as complications of hemophilia itself or of the therapy for hemophilia. So inhibitor development, target joint development, bleeding that's out of proportion for what you would expect with a various treatment, bleeding into your head, that's what intracranial hemorrhage means, having to be overnight in the hospital, dying, of course, dying would be a poor outcome. Transfusion transmitted infections, this is a issue obviously back from the 70s and 80s with HIV and hepatitis. We don't really see that anymore with modern therapies, but it still is considered a poor outcome because there are many of our stakeholders who are still dealing with these infections. Thrombosis or blood clots where you don't want them. So for example, there are, with some of the medicines we use in hemophilia, they make you too clotty. So you can run in the risk of getting blood clots or thrombosis, any kind of new heart problems, any new cancers, any neurologic events that have to do with your brain, such as a stroke, and then unexpected poor efficacy of a product that you might be using. So that's how we try to figure out what medical providers feel would be a poor outcome. Next slide. We took a very different tact with figuring out what patients and caregivers felt was a poor outcome. So we collaborated with the NHF for this part, and we sent out a survey using NHF's app, the Community Voices in Research. And this app collects information from people who are directly affected by bleeding disorders, either those with the bleeding disorders themselves, parents of people with bleeding disorders, siblings of people with bleeding disorders, partners of people with bleeding disorders, other caregivers of people with bleeding disorders. This app allows us to push out questions to people who have agreed to use the app, and then get in return confidential and de-identified responses. We collected this data over 10 days, and we sent out intermittent reminders via Community Voices in Research to remind people, if you haven't answered this question yet, we're trying to get an idea of what your thoughts are, what a poor outcome is. Can you go to the next slide? So these are the questions we asked. We asked some super basic demographics questions, just who are you? And we wanted to know if it was someone who had hemophilia A, someone who had hemophilia B, or a caregiver of someone with hemophilia A or B, and then what their age was. And then we asked two questions. The first question we asked was, what makes living with hemophilia better or easier to live with or easier to tolerate? And why have the improvements in hemophilia care been important to you? We allowed completely free text. We didn't limit responses. We didn't give preordained choices like we did for the medical providers. We wanted to see what exactly people thought. Then pertinent to what we're trying to figure out for this project, what are the difficulties or the negative impacts or the consequences of living with hemophilia for you, and what does hemophilia prevent you from doing? So here's what we've had in terms of response. Providers, we got 14 respondents, a predominance of pediatric respondents, so that was pediatric provider respondents. That was interesting. And from the Community Voices in Hemophilia, we got 64 people who responded, 44 people who had hemophilia A, 11 who had hemophilia B, 8 people who care for people who have hemophilia B, and 1 person who cares for someone with hemophilia B. So I would love to be able to share the information with you, but we are deep in figuring out how to analyze these responses right now. We are taking a qualitative research approach to these responses. So this is a branch of research where you can take free text and come up with what are called exemplars or examples. And what I can tell you is, having read through all of the CVR responses, that I can group them in approximately 8 or 10 buckets. Like, I don't like the fact that I have arthritis and pain in my joint, or I don't like the fact that it has inhibited me from traveling where I want to travel. What I can tell you is that this is going to be super interesting, in that we're going to end up with two different models of what a poor outcome is. We're going to end up with the provider model of poor outcome, and we're going to end up with the patient caregiver model of what a poor outcome is. And to me, as a clinical researcher who has been asking questions that I thought have been important for the past 25 years, it has really opened my eyes to always remember that what I might feel is an important question to ask might not always be exactly the same question that patients or family members or other stakeholders might want us to be asking. And I think anybody who attended the webinar on the state of the science a couple weeks ago, you know that Dr. Valentino has made it very much central to that state of the science, in that the patient and family voice is going to be heard in the entire process. And the way we decided to determine this definition of poor outcome was really informed by my work with Dr. Valentino on the state of the science and making sure that the patient voice is being heard when we make up this definition. So I think the next slide might be the last. So these are the next steps in the process. So I would say within the next couple of weeks, we're going to have our final determination of what the definition of poor outcome is. And like I said, I'm predicting that we probably have either two separate definitions or build a definition that includes both the medical provider and the patient perspective. The next step would be bringing in our friends from the Center for Digital Health Information to help us train Athens 7 in coming up with this predictive model. And then we'll use the model that is developed from that research quality data to validate what we found out using the larger Athens data set. And then one last click. The whole idea is this project will help us transform the care of people with hemophilia. If this works, we obviously will extend this to other bleeding disorders. But because the grant wanted us to focus in on the hemophilia population first, that's what we decided to do. So this has been, to me, I'm 58 years old, I'm coming to the end of my career, such an incredibly exciting learning experience that I can be part of a project that uses artificial intelligence, right? I'm of the age frame that 2001: A Space Odyssey, I was a kid when that came out, and that movie scared me. And what I remember, like going home from that movie and like, I'm not sure I'm going to be able to sleep tonight because Hale might like reach out and get me. So we're gonna, we at Athens are going to be using this technology for good. So I think that's the end of our presentation. Moses, anything else that you want to add?
I don't think so, Mike. I think we're ready for questions.
Great. We do have several questions that came in. None of them have any movie references.
Yet.
Yeah. Very, very, very interesting. As these start to roll in, the first question comes in and says, what would be required from an infrastructure level to integrate deep learning applications within bleeding disorders care?
Sure, that's a great question. Mike, you okay with me taking this?
Yeah, can I grab that one, Moses? So computers are all zeros and ones, and
so it's on the technology side, it looks very different. So when we're doing sort of machine learning, you can use sort of regular processors, so your average sort of desktop computer, and that's fine. When you're doing deep learning in these neural networks, you're actually using something called a graphics processing unit. So this is your video cards, the thing that actually makes your video work. And on your computer are actually themselves very sophisticated processors. They operate in a very different way than the processors that sit inside your desktop. So they are, or think of them as thousands of computing units. They all operate in parallel. So when you're doing deep learning, you're running the same calculation millions of times. So you want a processor that's designed to say, I can run the same calculation 10,000 times in a second, right? And that's very different than the processor that's actually running Word or something like that. So on the infrastructure side, you'd want a large computer that has many of these graphics processing units in it. Each one is capable of running tens of thousands of transactions a second. And then you might have multiple of those machines actually working against the same problem. So from an infrastructure side, it does look substantially different than what you would do for machine learning.
Moses, is there any way that you can multiply the power by having a bunch of people's machines all working together at the same time?
You can. It's really interesting. There is a tool I think Amazon has built where, Amazon has this very large cloud, and they have thousands of machines in it. And there's a company that's built a product that sits on top of Amazon's cloud where it does this exact type of modeling, but it uses, for all the times that those machines in that cloud are idle, it takes the 1 minute from this machine, the 10 minutes from this machine, and then runs those thousands of calculations across it. So it's very much a real product that's actually doing that. There's also, I'm sure many people are familiar with the SETI at home, where basically, if you want to, a lot of sci-fi references today, but where you want to, help identify signals that they receive from outer space, you can run this on your computer. And then there are millions of people who do this. And what's possible then is that, they each get a little subsection of data to analyze, and then it sends the results back. So there are definitely practical models of people doing it. I'm not sure how practical SETI at home is yet, but it does work.
It's great. Great. Thanks, Moses. Appreciate that. The next question that comes in is, in developing the model of poor outcomes, what do you foresee as the greatest barrier?
The greatest barrier to developing the model at all. So I think from the provider side was the relative lack of response. So, probably a third of patients with hemophilia in the United States are pediatrics, but about 3/4 of the respondents were pediatric hematologists. So we might have got a little skew from that. And why would that be? Well, I can tell you as a clinician that we get requests for doing surveys, 1,000,000 times a day. So the fact that we were on such a tight timeline and we weren't able to allow a longer period of time to get more input, I think that could be a potential confounder in our responses. From the patient side, I couldn't be happier with that collaboration we did with Michelle and Maria at the NHF to use CVR. Now, the risk, of course, there is that the people who use CVR are a selected population. Not everybody's using CVR. So, but still, there is no way we at Athens could have gotten that number of responses so quickly. And I can tell you the responses were incredibly thoughtful and really in depth.
Great. This next question actually dovetails really well into that, Mike. And this comes from Lawrence, who's joining us across the pond in the UK. He said, this is a great webinar, and said, how do you ensure the 64 community respondents were a representative cross-sectional sample?
Yeah.
We know those already activated and engaged normally respond to new health opportunities rather than those sustained barriers to engagement.
Yeah. So I think Lawrence, that's really the biggest issue, that with the time frame we had, we did the best that we could do. We do have those basic demographics. It turns out that, the number of people with hemophilia A compared to the number of people with hemophilia B that responded, that seemed to be right on from the demographic standpoint. We had more women respond than you would expect from, what we know is the population that received care through the treatment center network in the United States. So I don't think we'll ever be able to claim that we have a perfect representative sample, but we will be able to say we've got a sample from people that we would not have been able to reach otherwise.
Great. Great. Thanks, Mike. Next question that comes in. How can your findings and models be translated to the clinical setting and improve clinical care? What do you foresee as the greatest implementation barriers within the HTCs? Great question.
Yeah, that is a great question. So that's the whole idea. The whole idea is to create a model that, potentially when a baby is born, you press this button and you take all this information that we can input and say, this kid has a higher risk of developing these 3 complications, and therefore we recommend this type of therapy to mitigate those risks. For older people, the question might be, okay, someone has had these complications. What would be the next step to try to minimize future complications?
Great. Thanks, Mike.
Moses, do you have any sort of follow-up or thoughts to that?
I was thinking there are some HTCs that have their own sort of risk profiles that they developed too. So there might be opportunities in the future where this similar technique might be combined with their existing risk profiles and linked together, potentially being open as a more comprehensive way of thinking about the risks associated for individual patients. I was thinking specifically around some of the work that Dr. John Fargo was doing,
Yeah,
and how that might apply.
A few more questions that continue to kind of roll in here. How will you reconcile responses from the healthcare providers and those with the lived experiences, or so-called subject matter experts, also known as patients? Is there a need to reconcile?
so I think that's a really good question. And what I would say is, in my preliminary review of our responses, we do, think about it as a Venn diagram, right? That we have the subject matter experts responses and the providers responses, and there's pretty significant overlap between the two. But there are certainly areas that the subject matter experts have brought up as complications that were not even on the radar of the providers. And then, for example, just to give a really solid example of why I sort of think, the fact that we had so many pediatricians respond might be skewing the results. The providers rated inhibitor development as a worse outcome than death. So, we are going to have to use a little bit of massaging to figure out how to do this. Do I think we actually have to reconcile? No, I don't think we necessarily have to. I don't think there would be any problem with trying to come up with a model that would have 2 definitions of poor outcome.
Thanks, Mike. The next question that comes in is, have you considered diversity when asking questions to patients and caregivers? And are you planning on integrating the voices from those patients and caregivers not represented in CVR?
Yeah, so this is a big issue. And Michelle and Maria and I and the team at Athens really struggled with this because we were on such a tight time frame to meet the various goals of the grant. We used CVR as our first attempt. I think what this will do will be exactly this. This will be our first attempt. If we are able to come up with some sort of protocol that could predict poor outcome, that would be essentially just a demonstration that the technique works. It doesn't necessarily mean that our definition is the best definition. So the next steps would be to figure out a way to reach all of the population, to make sure we are taking into consideration the lived experience of everybody with bleeding disorders.
Great. Thanks, Mike. Another question that comes in. In other areas of medicine, machine learning and AI are being actively used to predict outcomes. Can you give some examples of where this has been successful?
Moses, you wanna? I think the one that I talked about was, reading chest X-rays. That's a really, pretty concrete way of doing it. The other one is Pap smears are pretty much all read by machines now and have a much higher reliability than pathologist eyes.
And another example was, I know Google had this tool for a while called Flu Finder. And the way that what it was based off of was essentially taking data based off of searches, applying a machine learning algorithm to it, and then being able to pretty accurately predict the transmission of flu between geographies and watching it sort of transition over time. It was a pretty accurate predictive tool for things like flu outbreaks.
That's great. Another question that came in. Have you received any negative feedback or resistance from the community in regards to utilizing technology in this way? And if so, how have you mitigated this?
I think that's a great question. I was going to actually ask Moses that myself. Like, what are the risks of AI and machine learning?
So, I think we've all experienced that with the potential risk of how some of these techniques can be used for ill. If you think about, the controversy behind some of the big tech companies and how they use data. When they talk about using data, they really don't mean, some data scientist running traditional queries. They're thinking about some data scientist building some algorithm that says, that creates some new behaviors. And we've seen a bunch of behaviors in the public space where have been less than ideal to democracy in general. That being said, in the medical space, there's certainly things we need to be aware of, right? There's potential bias that can be created between it and how the data is being analyzed that we need to consider. There's certainly the concerns around, identification of people, particularly if we think about mixing and matching data sets. We're really careful and think really hard about issues like that. So that's not a concern for this particular project, but if we were to say have multiple data sets from different organizations that we're also feeding into this model, maybe with the US Census data, we mix it together, could we identify someone that has a fairly rare disorder in the United States? And it might be relatively easy to do. So there's concerns like that where we have to really be careful stewards of both the technique and of the data that we're using. So we have to think through sort of all those sort of challenges as well. As a whole, I think that there's a lot of value here and that we don't want to turn away from the benefit that the community could get from applying a technique like this to the data to actually help patients, live better lives. We do have to, be good stewards as both as, the NHF, Athens, and the community as a whole. We all just sort of have to be really good stewards of both the technique and of the data.
Yeah, great. Thanks, Moses. Lana, I see you've got your hand up there. I don't know if you wanted to add anything or ask a question.
Yeah, so first of all, thank you for an excellent presentation. It's really informative and thought-provoking. So my question is, will you look to integrate precision medicine principles and omics, whether that's genomics or transcriptomics, proteomics, data into the modeling? And where will that data come from? And what role do you think, future projects like My Life, Our Future can play into this?
Yeah, thanks, Len, for that. So in this first iteration of the projects, those biologic data points are not going to be included in our modeling or in the definition of a poor outcome. They might end up being pulled from Athens 7 because we do have the genetic information from some of Athens 7, most Athens 7 participants. We've got, the My Life, Our Future genetic data from anybody who is elected to share that with the My Life, Our Future research repository. So my response to you is you as the study section chair for awarding the My Life, Our Future projects, expect for round 3 of that a proposal from Athens to use that exact data.
There are a couple more questions that came in, if you guys don't mind me asking here. The next one is, can the chapters provide additional input into the outcomes for the model to further refine it?
The very short answer is yes, of course. It may not be in this first iteration, but in any further iteration, 100%.
Great. And there's one last question that came in, and I'll ask you to both answer this separately. I think it's a good wrap up, but it's a simple question, and maybe not so simple, but it's what inspired you to embark upon this project?
Mike, you want to go first?
Okay. But to be very honest, there was a grant opportunity. So we're always looking for ways to utilize the information that we collect at Athens to better the care of individuals with bleeding and clotting disorders. This opportunity came up, but also it was it gave us the potential to collaborate with a new group of people. So that's always exciting, to bring in the people from University of California, San Francisco to help us with this project. It solidified our growing collaborations with the NHF, which is always a pleasure. And it's, just sort of cool. So what I want you all who are listening to understand is we approach this project with the appropriate trepidation, knowing that we would make, if this works, that we make a little bit of a leap forward, but it's not going to be perfect the first time. And we just want to see if we can even make it work right now. And then if we can demonstrate that it's a feasible approach, we then go through these various iterations to make it as good as possible.
Yeah, I would echo everything that Mike said. I came about from really the technology side at Athens, and I always have this desire for us to take the technology that we have and figure out what's the best way that we can apply it to whatever challenges the community is facing. And technology never stays static, so we want to, as an organization, always be taking the latest techniques and being able to pull the good parts from those techniques and then apply them to move the mission forward and to help the community. And that's a big part of my driver for making sure this is something that, if it works, how can we then, my goal would want to make it available to every HTC, right? And then after every HTC, maybe it's every, doctor's office where they're seeing patients, that have one of these rare disorders that we actually have data on. And this is a valuable tool. That's very ambitious. I recognize that, but that's sort of the mindset that I like to sort of cultivate and hold on to. We really wanted to make sure that technology I see as a force multiplier. It's going to allow us to do so much more with the same resources, to offer all new possibilities. And at the same time, as Mike said, that appropriate trepidation is there. We have people like Mike and others at Athens, and certainly through our collaboration with NHF, who, ask good questions about, should we actually be doing this, right? Does this make sense for the community as a whole? Yes, this sounds very cool, but maybe it's not the right thing. And there are all these other sort of ethical issues we need to consider before we move forward. So we're pretty balanced in our approach as we move forward. So, when you're thinking about this project and Athens and how we're thinking about new techniques, because there's new technology, just know that, we're doing it in as good faith as possible, and that we have checks and balances internally, and that we rely on our external partners for some of those checks and balances as well, so that we're trying to do the right thing at sort of at all the times.
If I can just add one more thing, when I came over to Athens, the question that I asked Crystal and Moses is, tell me what Athens' purpose is. What is the mission of this organization? And, it's really sort of simple. It's really a three-pronged mission: collecting appropriate and secure data, using that data to advance our knowledge. And advancing knowledge is in and of itself a great goal, but really the ultimate goal is how we're going to take that knowledge that we're creating through Athens and transform the care of people with bleeding and clotting disorders. And this is one of those projects that really fits into that three-pronged mission of Athens, of securing data, advancing knowledge, and transforming care.
Great. I will keep you guys for one more minute. We have Rios from Brazil, and I'd hate to, he just sent a question, and I'd hate to send him off from all the way from Brazil not answering his question here. So firstly, he said, congratulations on the excellent webinar. I think we all echo that. He said, my question is about the current use of machine learning to model hemophilia data. Machine learning methods have been widely used in several applications. Do you know how this is state of the art in this area?
I'm not aware of really another project in hemophilia. I know that in other diseases where techniques like this have been applied, but I'm not sure if anything specific in hemophilia. Do you know, Mike?
I think maybe the closest thing that would be like this would be Dr. Iorio's population-based pharmacokinetic WAPS hemo.
That's right.
They did a lot of, machine learning is how they have come up with their models.
That's right. Yeah.
Great. Well, Moses and Mike, thank you so much for joining us and for taking the time and
Sure.
your expertise. We really appreciate you being here. And
Hey, Brett, is there a possibility that we can get a list of all the questions that came through today, so we can think about these as we're working on the project more?
Certainly, absolutely.
That's great.
No problem at all.
Thank you both. Great presentation.
Yeah.
Great.
Really
Thanks
is.
for having us.
Please note, everyone, that the webinar will be available on Friday, July 23rd at hemophilia.org under the events tab with all of our archived webinars. Also there on the events tab is our upcoming schedule for our Wednesday webinar series. Again, Mike, Moses, thank you so much for joining us. We appreciate your time and expertise, and we'll talk to everyone soon. Thank you.
Thank you very much. Bye.
Bye.